share.
So if she, okay, and let's. So the better way is André Rolinco, the translator, can translate from Portuguese to Spanish, right? No problem. And André Lins can translate the Portuguese to English. Okay, just this part.
Okay, I can speak in Portuguese.
We prefer in English, André, if you could.
Okay, my English is a little bad, okay? I will try, okay? So sorry. I speak Portuguese very well. Okay, about biotech, my name is Andrea Passos, okay? I am working biotech in 2 months. Biotech, to be in the market em 22 anos de história. Doutor, acho que eu não vou conseguir, eu vou falar um pouco de português e um pouco de inglês, ok? I will try to talk a little in Portuguese, a little in English, okay? Biotech to be 90 países, ok, today. Isso são as nossas fábricas. Nós temos fábricas na Irlanda, 2 fábricas na Argentina, aqui as nossas instalações. É uma empresa que investe muito em tecnologia, nós temos aí certificados de qualidade bem importantes, ok? Sobre a nossa lente fásica, que é o que interessa a todos nós, ok? A EyeCryl fásica, é uma lente de câmara posterior para pacientes míopes com ou sem astigmatismo. E aí, quais são os grandes diferenciais da nossa lente? O processo de carregamento da lente é mais simplificado, então não tem todas as complicações da nossa concorrente. Ela não necessita instrumentais especiais para a execução da cirurgia. Hoje nós temos a grande vantagem de ter a menor incisão do mercado, 2,8 milímetros. Isso é muito bom para astigmatismo, correção de astigmatismo. Ela dispensa iridectomias periféricas. O material é um material moderno, avançado, ok? E nós temos aí para miopia de menos 6 a menos 20 e a tórica com cilindro de 5. Os candidatos são pacientes míopes, acima de 21 anos, com refração estável e com câmara superior a 2,80. O que é necessário para fazer a cirurgia, né? Além de ser um cirurgião expert, você ter aí atenção em relação aos exames, né? Então, ter uma biometria, white, topografia e contagem de células endoteliais. O cálculo da lente, ela prevê o cálculo realmente do diâmetro da lente, porque ela fica no sulco, e o poder da lente. As informações são refração, ceratometria, ACD, white, paquimetria que nós necessitamos, tá? Eu digo sempre o seguinte, que nos casos de medidas extremas, a gente tem que ter aí um pouco de atenção, as medidas menores ou as maiores. Aqui o white, que é o que define o tamanho da lente, o white associado ao ACD, que esse ACD é até endotélio, 2,8 milímetros. E essa tabela aqui é bem interessante, que é um nomograma que mostra aí a associação de white com ACD. Então, dependendo do ACD que você tenha, o tamanho da lente, ela tem uma modificação. E como eu disse antes, o tamanho é fundamental aí para o sucesso da cirurgia. Em relação à refração, esse paciente corrigido ele tem uma boa qualidade de visão. E a implantação é o que a gente vai assistir aqui com as 3 cirurgias, né? Mas eu digo que esses 5 passos são passos importantes aí para a gente ter um sucesso da cirurgia.
Andrea, sorry, can you see the presentation? Because I don't know if you are moving forward with the presentation.
You didn't see the presentation?
No, Alessandro either. What about? Yes, try again, just in case. I don't know if the PowerPoint is freeze. Yeah, the same.
Okay. Would you like to restart the presentation of her?
Let's see. Let's try again to see if the PowerPoint works.
Can you see the presentation?
No, not yet.
Why? I'm sharing all the desktop. Let me see. No. Ok. Vai ser no... Sorry. Let's try. Aqui. Zoom.
Jonathan.
We'll try again.
Okay, you have to just share.
And now.
Yeah. Can you share the screen? I think it's easier, right? Just share the screen. Can you help there? Or it's not sharing the screen there, not on the, oh, okay.
Okay, now I can see the presentation. You have to go to presentation mode.
Okay.
Yeah.
Yes, right?
Okay, now it's working.
Okay.
No, there.
Okay. Perfect.
André, continue.
Hello. Ok, again. Você quer tentar falar em inglês? Você quer tentar
Não,
apresentar?
Vai devagarzinho.
Ok. Let's go. EyeCryl Phakic, nós temos a lente há 7 anos no mundo. É uma lente fásica de câmara posterior para correção de miopia com ou sem astigmatismo, ok? Os diferenciais da lente é um processo de carregamento da lente mais simplificado. Ela não é uma lente preload, mas é muito simples o carregamento dessa lente. Não é necessário instrumentais especiais para fazer a cirurgia, ok? Hoje nós temos a menor incisão do mercado, nós temos uma incisão de 2,8 milímetros, então isso é um grande diferencial. Ela tem um furinho central, então não é necessário fazer iridectomia periférica, ok? O material é um material mais moderno, avançado, é um acrílico hidrofílico, e a gente tem, assim, uma ampla correção, né? Miopia vai de -6 a -20 e tórica cilindro de 5. Os candidatos à cirurgia são míopes com ou sem astigmatismo, pacientes acima de 21 anos, a refração estável, e uma necessidade básica é ter um ACD superior a 2,8 milímetros até endotélio. Eu vou mostrar a imagem para vocês, ok? Ter uma contagem de células endoteliais acima de 2.000 e sem apresentação de outra patologia ocular, embora a gente tenha aí bons casos com pacientes de ceratocone. Os exames necessários para o sucesso da cirurgia é fazer uma boa biometria, ter realmente a confirmação do white-white com compasso, topografia e contagem de células endoteliais. O que é importante? Quando a gente faz o cálculo de uma lente fásica, a gente calcula o poder da lente, ok? Para reduzir ao máximo esse paciente ficar próximo do plano, e o diâmetro dessa lente, porque nós temos 4 medidas, e essa lente ela fica no sulco. Então, é importante a gente ter aí a lente com a medida correta. As informações que nós precisamos é refração, ceratometria, o ACD, o white-white, a paquimetria. Existem algumas questões que são importantes, é observar se o ACD foi descontado a paquimetria, porque a gente precisa de ACD até endotélio. E o white-white, nós sempre recomendamos descontar ponto 4, exceto quando é Orbiscan. Por quê? Todas essas lentes de câmara posterior, os estudos foram feitos com base no Orbiscan. E o Orbiscan, ele hiperestima as medidas branco a branco. Então, é importante descontar o ponto 4 para se ter uma lente correta. Situações que merecem atenção são medidas extremas, então 95% dos olhos no mundo, as lentes ficam entre 12,5 e 13, então quando a gente tem essas medidas extremas, eu sugiro que se faça uma reavaliação dos exames, tá? Medidas diferentes também, porque lente fácica, as medidas têm que ser as mesmas medidas em ambos os olhos. O que define a largura, né, o diâmetro de uma lente fácica? É a associação do white-white com o ACD. Então, essas duas informações que a gente precisa de ACD até 2,8 é que vai definir aí o diâmetro da lente. Essa tabela é bem interessante, porque é um nomograma, né, que mostra para a gente aqui várias medidas de white-white, e quando você tem aí alterações no ACD, a gente observa que a medida da lente é alterada. Então, essas duas informações, elas são fundamentais aí para o sucesso da cirurgia. A refração também é necessário muito cuidado, porque esse paciente corrigido é um paciente contente, né, com a correção, então tem uma refração aí muito assertiva. E esses 5 passos para a implantação da cirurgia. Então, ter uma boa avaliação, uma boa medição, alguma experiência. A técnica cirúrgica ela é muito parecida com a catarata, embora haja aí algumas diferenças em relação à técnica cirúrgica e a observação do pós-operatório. Isso aqui é bem importante porque, assim, a nossa lente, ela tem que ter esse buraquinho do lado esquerdo, diferente da ICL, que é a concorrente, né? Para ela ficar aí bem ajustada aí no sulco e não tocar no cristalino. No pós-operatório, é necessário observar a pressão intraocular, e pode ser que tenha algum viscoelástico aí retido na câmara, e o tamanho da lente, por isso que é tão importante a gente fazer o cálculo da lente, porque essa lente precisa estar confortável no sulco. E também o famoso VALT, que é a distância da lente até o cristalino. Então, é isso daqui que a gente está vendo nas imagens, né? Qual que é o VALT ideal? É de 250 a 750 micra, que significa meia córnea a uma córnea e meia. Então, aqui a gente pode ver um VALT normal, aqui um VALT muito excessivo, e aqui um VALT muito próximo, né? Então, quando existem essas situações extremas, é necessário que se troque essa lente. Aqui é a mesma coisa, um VALT alto e um VALT muito pequeno. Por isso que é tão importante aí a atenção no cálculo da lente. A calculadora da Biotech, ela é uma calculadora online, então, a qualquer momento, o médico pode fazer o cadastro e fazer o cálculo dessa lente, ok? Esse daqui é o endereço, convido a todos a fazerem aí o cálculo, estamos à disposição aí nos primeiros casos para a gente confirmar essas medidas, ok? Aqui é a nossa equipe, era isso que eu tinha para passar para vocês.
Okay, guys. Hello, I'm Rodrigo Santos. I'm from São Paulo. I'm a corneal and keratoconus specialist, and now I'm the head of sector of contact lens here in the Brasilia Hospital, Ophthalmological Hospital. And I will help to present some case. The first case of today will be performed by Wilson Takashi, the head of cataract division of this hospital, and the chairman of medical affairs of Opti Group. Let me find the presentation, the first case. this. And okay, let's share. Okay. Share. Can you see the presentation?
Yes, Rodrigo.
Okay, case one. Okay. The case one is a female patient, Caucasian, 21 years old, who desired to become independent of glasses. She had blurred vision without glasses, a high myopia, a dry eye, use of restas and Iobac and epithelial. She had submitted a photocoagulation in OS, no service, trauma, or infection. The familiar history is unremarkable. The one corrected visual acuity is 2400 in both eyes. The IOP was normal, no alterations of biomicroscopy, a little alterations of myopia in the fundus, and an angle open on gonoscopy. We did specular microscopy, a retinal mapping, a OPD, a biometry, and topography, thinking about IOL. This is the endothelial cells, a good cell density in both eyes. The pentagon show to us regular astigmatism. In right eye, the ACD is 3.5 millimeters and a CCT 496 micra. In the left eye, the ACD was 3.42 millimeter and the CCT was 494 micro. The biometry shows a good ACD, and this is the calculation of the EyeCryl Phakic. In right eye, Phakic IOL of minus 15.5, and the left eye minus 14. The patient had already submitted the surgery on left eye, and this is the first postoperative, and the uncorrected vision acuity was 20, 25, and 14 of IOP. The cornea was without alteration and a low equivalent, spherical equivalent. Today we will be perform the right surgery, and the incision was programmed at 25 degrees, the steep axis. Remember, the IOL chosen is minus 15.5. All right, let's go to the surgery. Takashi, are you hearing us?
Hi guys. Well, as you saw, this is a female patient. She has a minus 10.5 of myopia. You can see the eyes, classic myopia eye, right? You can see some signs of long-term using contact lens, and you can see the deep anterior chamber here. So she has a steep axis at 95, so it's where I'm programming the incision. So the steepest axis is for usually to combine the refractive surgery on this case, because she will do a refractive surgery after 2 months of this surgery with Dr. Marcelo Taveira. So let's start here. So you can see here I usually do an incision. Oops. Are you okay? Tá doendo? Can you sedate a little more? Okay, don't worry. Olha bem para a luz. Okay, she's feeling a little bit. It's usually for this little limber incision. I perform just for. Are you okay?
Guys, we have freeze the images.
Freeze the images, the surgery?
Freeze, yeah. We cannot see the video.
Okay. Wait just a moment. Let's, tá doendo? Vamos fazer um pouco mais de anestesia. Is it freezed?
Yeah.
Anestalcon. Hey, can you see the image?
No. I mean, I just see the eye, but it's freeze.
It's freezed.
Yeah.
Dr. Jonathan. I have an IT guy here. It's called Jonathan Lake.
He's going to help you now.
Yeah, he's the best of the best, you know. Well, I did already the incision, and the incision is a 2.75 millimeter blade. I performed on steeped axis. I already prepared the lens, so we're like putting on only the injection of the lens probably. But the thing is, usually people use a cohesive viscoelastic for these implantations, right? So I like to mix dispersive and cohesive. Can you see the eye? No, not yet.
Not yet.
Not yet. Not yet. What about if you share the screen? I share the screen. What about if we? Well, it worked the first time, right?
Yes, maybe you should try to stop sharing and try again.
I stop sharing and share again. Let's see.
Yes.
Good idea. Good idea. Or you can. Was it okay? Share again. Okay. Let's see. Okay. What about now? The video forever.
It's starting.
Can you see?
Not yet.
Yes. That's a reading. So you can see the eye already?
No, not yet, Takashi.
Okay.
It's like the screen is sharing. Wait.
Yeah, we're trying here to correct the connection. Probably it is. We think it's the connection, but because we are watching here very clearly, everybody, even. Yeah, I can hear. Yeah. Yeah, probably. Yeah. I think we can reconnect again. Probably. Oh, yeah, I think you can share again. Yeah, open share again. No.
So, Rodrigo, what's happened with the surgery? We cannot see
I guess the camera stop to transmit the
Okay,
no. Okay.
we're ready.
Now we see.
Perfect.
Yes, perfect. So it's freeze again.
Sorry, the
Can
camera
you
was,
hear?
yes.
Can you see now on the eye again? Can you hear me, guys?
Yes, Takashi.
Yes, in here.
Okay. Can you see the eye?
Not yet.
No, no,
Not yet. No. Yeah. Try the 4G, or can you pick my? Yeah. I think I have another connection. Oh. Yeah, we're trying to put here the eye in the system. We always have we have done a lot of live surgery with the system. Let's see how it's working now. So mainly the calculation is a little bit different from the other Phakic IOLs. I probably had implanted more than 200 cachet, the Alcon Phakic. Hi, can you hear me?
Yes.
Hey guys, can you hear me? Okay. Yes. So basically, I was telling I have used a lot of different IOLs. Oh, okay. You can see the eye now?
Yes.
Yes,
Yes,
Takashi.
perfect.
Okay, perfect then. Let's do. Okay, so implantation, I told you, put the viscoelastic here. The viscoelastic I mix dispersive with the cohesive. It's a kind of a inverted shell technique. So this step of the IOL, I do it very slow, because you want the lens to open in the correct way. See? So very slow, very slow, very slow. Never worry, very slow. See? Okay, so this is a real basic step, okay, because the anterior chamber is really large enough to move the lens here, see? So now I'm rotating the eye to the correct position, see? So putting the viscoelastic above the lens is some way how to not touch the lens, right? So you must, like, different as cataract surgery, you have not to touch the crystalline, right? Because the crystalline here is a young crystalline, and you can feel it very well. See, so the position is Caesar 95 degrees of the incision. So I'm pointing now the positioning of the optic. See, and you see this is a special instrument to position the haptic. Usually I choose as the nearest point, easiest way to position the haptic. Just a reminder, you must put always viscoelastic, make the lens have a very chamber to have this, you know, these movements, very careful. You know? So this is the second eye of this myopic eye, right? The first eye was like 5 myopia, or it was 15. So this eye is 10 and a half. So it's had a little bit different structure as the other one, right? Okay. So since I mix cohesive with dispersive, and the whole idea is to have less movement on the iris, right? So using the EyeCryl is used already on this kind of step, where only already the positioning of the lens. Okay. So after positioning well the lens with the EyeCryl, you can see if you can reconfirm the position of the haptics, right? But a little bit of EyeCryl helps to see if the haptics is really upside, because we were talking with Andrea about the vault position, right? So we have always to be careful about the vault position. See, so a little bit of dents. You can see the viscoelastic coming on the hole that you share. That this hole is the way that you don't need iridectomy for the surgery, right? The old lenses, we needed iridectomy, right? So now it's done, okay. So the danger part here is to do the misdirection, okay? If you do a BSS flush here and go to the anterior vitreous, is a really bad thing when it does a misdirection, because misdirection gets like a very hard IOP, and getting in the way to get out this high IOP is probably doing myopic. You have to do the dilatation again. Okay, so see, it's a very, very fast surgery, very secure. So this patient, you can see she has a little bit of keratitis, right? Because she was waiting for the surgery, but she has dry eye, right? We're talking about her cases, right? She used the rhistasis and the dry eye always whole life, right? So that's why this indication on the Phakic Iol was perfect for her. Okay, so the surgery is done. Very easy, fast. Okay, sorry for the transmission. Okay, finish. Okay, thank you very much. Rodrigo.
Very good. Congrats, Takashi. Now we'll present the second case.
I think you need to take out the share here. Can you take the share out here? Jonathan, take out the share. Okay, guys, really fast. Now you can go to the second case, and then we can go direct to the Daniel Moon.
Pode sentar.
Tá doendo? Tranquilo?
Could you see the presentation? Can you see? Yes, okay. Let's go.
Good evening. I'm Mariana Madeira. I'm currently in the second year of Fellowship of Cataract and Lens here at the Hospital Oftalmológico de Brasília. And I'm going to present the second case of tonight of Phakic Iol. Our patient is a 30-year-old white female with high myopia in both eyes. She presented blurred vision without any pain or redness. She reported no previous surgeries, trauma, or infection. Also, unremarkable medical events. She presented an uncorrected visual acuity of 2400 with both eyes. The refraction, she presented 12.5 myopia in the right eye. In the left eye, she presented 12.5 myopia and 0.5 of astigmatism in the 120 axis. Her biomicroscopy presented normal anterior segment examination in both eyes, normal intraocular pressure in both eyes. At the gonioscopy, she presented open angle in both eyes, and in the fundoscopy, physiological optic nerve, normal fundoscopy examination in both eyes. For the propedeutic, we used the following exams: topography, specular microscopy, retinal mapping, and biometry. Here we have the topography. In the K1, she presented 45.8, K2, 46.2, a low astigmatism of 0.3, and the pachymetry, center pachymetry of 508 micron. The left eye, the topography, K1 45.4, K2 45.8, also a low astigmatism of 0.3, and the center pachymetry of 504 micron. In the specular microscopy, she presented a normal cell density in both eyes. In the biometry, we used the IOL master for both eyes. And here we have the calculation for the Phakic IOL, for which we mainly use the Pentacam and IOL master. As a convention, for the calculation of the Biotech Iol, we discounted 0.4 from the white-to-white value, and also discounted the central pachymetry converted in millimeters from the anterior chamber depth value. And we had these values here for the right eye and for the left eye. Today is the surgery of the second eye. In the 4th day of postoperatory of the first eye, which was the left eye, the patient presented an uncorrected distance visual acuity of 20/20. So she was totally satisfied. And a refraction of plano, normal intraocular pressure. And today we proceed with the surgery of the second eye, which is the right eye, which will be performed by Dr. Daniel Moon, which is the head of cataract division of INOB. Thank you.
Okay, guys. I guess they are preparing the second patient. Daniel Moon is, can you hear us? I guess not, but cadê a Andrea da... Andrea, we guess we have questions in the chat. O Jonathan, será? Estão perguntando. We're waiting for surgery.
Hi, Rodrigo.
Hi, Daniel.
Can you hear me?
Yes.
Okay. So, could I begin the surgery?
Okay. Daniel,
Okay.
would you like to comment some tips of the Phakic IOL that you recommend?
Okay.
Or
First of all, thank you, everyone. I'm Dr. Daniel Lee. I'm a cataract specialist, surgeon, and today we're going to do a Phakic AOL surgery. It's the second eye of this patient. She's a female patient of 30 years old, and she has a high myopia. So we are glad that we could give opportunity to give a better vision to these patients, for these patients that have a high myopia or a very thin corneas and were not able to perform a normal refractive surgery in the cornea. So using this kind of intracoal lens, we can give these patients opportunity to have a very good vision and correct vision and a very better life. So we have some tips for this kind of surgery. Actually, I'm a beginner in this kind of surgery too, but as a cataract surgeon, we are used to manage intraocular lens. It's a different kind of intraocular lens, of course, a different situation, but how we are so used to manage this kind of lens, I think that cataract surgeons have more facility to manage this kind of surgery. But it's a different kind of surgery, of course, because we are not going to take off the lens and we are only putting an intraocular lens in front of the natural lens, okay? So my first tip, before doing any incision, is better to prepare the lens in the cartridge, because if you have any problem with the lens in this phase, we can abort the surgery and ask for another lens and do it on another day. So first we are going to prepare the intraocular lens, okay? Can you see here the image of my microscope?
not yet. Let's.
Yet.
O Jonathan lá?
Compartilhar
Compartilhar o microscópio.
Because the right preparation of this lens is essential for the final result, of course. In a normal cataract surgery, even if you put are you seeing the image of the cartridge?
Yes.
Okay. And in a normal cataract surgery, if you put the lens inverted, you have much more space to rearrange the right rotation of the intraocular lens. But in this kind of surgery, you don't have this space. Even in high myopia patients, with a higher anterior chamber depth, you have to take off the lens and put it again if you put it inverted. So to avoid it is essential to prepare it right. Okay, so we have to put in the viscoelastic in the carriage. Here we have the lens. Can you see the holes that we can use for orientation? In this horizontal position, the holes, the marks are in the left, in the bottom, and in the right, in the upper side. But when we are going to put the intraocular lens, the mark is on the left. And we have to check it to put in the right position. So on the cartridge, you put it the right way. And you have to put all the lens inside this inner part. And actually you can feel when you are pushing the lens, and then the whole lens inside this part. Right. And you cannot put the lens too close to this part and too close to this part, the end of the cartridge. So in the middle, and then you close it, and have to be easy, okay? And then put it this way. Okay. Did you hear the click? So when you push it, you see that the lens is moving a little bit, okay? So you can push and then pull a little bit to be sure that this part of the injector is not together with the lens, and the lens is free, okay? So the lens is ready, and now we are going to do the incisions. Pode subir a maca pouquinho. Tá bom. Okay, so this is the right eye of the patient. And in this case, the axis is 170 on the temporal part of the eye. So Biotech usually recommends temporal incision, and they recommend 2 percentages. I recommend that if you are beginning this kind of surgery, to keep these recommendations, and then with more experience, you can adjust your technique. So I'm doing the 2 percentages. And usually I like to use intracameral anesthetic to give more comfort to the patient. Okay. And seal the anterior chamber if necessary to the main incision, because the main incisions have to be soft and smooth, because the worst thing that could happen in this moment is have a tear in the anterior chamber and anterior capsule. And I use a 2.75 millimeters incision too, but my second tip in this case is to try to put the whole point of the injector inside the anterior chamber to control better the injection of the intracoal lens. So we have to do it slowly. And we can see the left part of the lens, the whole of orientation, right? Slowly. Right. So after injecting the intraocular lens inside the anterior chamber, you can feel, put a little more viscoelastic above the lens, and then perform the positioning of the haptics of the lens. You can put a little bit more viscoelastic to deep the anterior chamber to facilitate this maneuver. And then softly you put the distal haptics first, and then the proximal haptics behind the iris. And that's all. This kind of lens centers very easily, and if you consider the mydrias is very big, you can use an neostat to avoid any movimentation of the lens. Here we can use only the flushing of the viscoelastic, or if you have, you can use an IA handpiece to drain this viscoelastic. So you can see that the lens is very stable. So the toric version of the lens could be a very good correction of high myopias and even with significant astigmatism, and improve the uncorrected vision of these patients. This patient in the left eye has a uncorrected 20/20, and she's so happy. And I'm sure that she's going to be happier with the second eye surgery, even today. Okay, and in this case, I don't gonna use myotics because the lens is so stable and centered. So I consider that I don't need it. Okay, thanks so much. That's all.
Okay. Congrats, Daniel. Andres, Bernard, we have some questions. I don't know if you want to.
I'm here, guys. How are you?
Do you want to ask the Daniel or Takashi to answer these questions, or would you like to present the last case?
Yes, there is a question here. There are so many questions, but we're going to try to ask some of them. What kind of anesthetic are you using for intracameral, and what concentration and dilution? And
I don't know.
And another question is about if we can do both eyes in the same day, or would you rather to do it in different days?
Yes. Daniel or Jonathan or Takashi, could you answer these questions? It's in the mute.
Takashi, are you here? Are you in mute? On mute.
Okay. Daniel is here.
Hello.
Hi, Daniel. How are you? Amazing surgery, first of all. Congratulations.
Thanks so much.
Beautiful surgery. One of the assistants asked about the anesthetic that you are using for intracameral, and what kind of concentration and dilution you used to use.
Okay, I used for several years all my cataract surgeries, and in this kind of intraocular surgeries that I use topical anesthesia. I think that this kind of intracameral anesthetics helps a lot, because some patients, if they feel not comfortable, they don't help during the surgery, and they can worse the results for sure.
Okay, and perfect. And Daniel, do you do the both eyes at the same day, or would you rather to do it separately?
No, for me it's the same discussion of bilateral surgery, of cataract bilateral surgery.
Okay.
For me, we have reasons for both parts, of course. But for me, it's not my option. It's not an option for me. It's not my choice. I prefer to do HI in one day.
Perfect. And the last one from Argentina, Noel Rivero is asking you, Daniel, which viscoelastic do you suggest to use in this with this lens?
Very good question. It's normal to think that a cohesive viscoelastic is best for this case, but even Biotech recommends that you can use normal viscoelastic. I just use viscoat as my normal cataract surgery. It's a normal kind of dispersive viscoelastic. It's worse to put out of the eye with this flushing for sure.
Mm-hmm.
But the central hole is to avoid an angle closure crisis, but it helps too in this viscoelastic taking off of this viscoelastics, right, for this hole in the central part.
Perfect. Awesome. And the last one before we start with Jonathan, because I think it's a very interesting question also. It is possible to use another instrument to manipulate the IOL in the anterior chamber?
Another excellent question. In the first eye, I didn't have this fancy instrument, and I used my normal Sinski instrument. And my Sinski is very small, with a very regular point to avoid damage of the intraocular lens, and worked perfectly on the first surgery. And I use this instrument today for the first time, and it's very good, perfect instrument. But if you don't have it, I think normal Sinski is perfect too.
Thank you so much, Daniel. And again, congratulations for your surgery. It was pretty amazing. Thank you.
Thanks so much.
Jonathan, could you hear me?
So Jonathan is in the OR.
Okay, I'm sorry. Okay, Takashi, up to you. Whenever you want, we can move on and keep watching these amazing surgeries.
Yeah, some people ask here on the Q&A about the difference between the ICL lens and the IOL from the IOL, I think the APC IOL, right? The
IPCL, the Indian, I think so. Yeah.
The Indian, yeah. I don't have this experience. I only implanted about 200 cachet and probably about 300 ICL, and I don't have so much experience with other Phakic IOL. I have done a lot of Artisan and Artiflex as well, but I believe the quality of the IOL on the sulcus is better than on the iris. Some people think it's not the iris is better, but I think it's a surgeon choice, right? I think there is different benefits, right?
Mm-hmm.
And the other question is about how do you recommend calculating white to white for these patients? Oh, it's Noé Rivero, our great friend, Noé Rivero. Yeah, white and white. Usually I use Pentacam and the IO Master white and white, and I have a electronic ruler that I use, that engineer uses, digital one, and then you can measure it on the slit lamp. Sometimes you can do this measurement with a engineer ruler. It's a really easy thing. It's like $5. You can buy this kind of ruler. It helps a lot calculating the white and white because machines not always measure correctly, because this myopic patient uses a long-term contact lens, and they have a little bit of panus or glaucoma because of the lens. The other question is, it has an optic smaller than 5.5 according to the design. They perform scotopic and photopic measurements of the pupil to the patient before the surgery if they are good candidates for the pupil. Well, I don't believe you need that, because as you saw, my patient, the pupil started to get smaller, and even though you can correct it intraoperatively, you know, because you don't have no problem because the meiosis is coming on, but I think for a as a pre-exam, I think it doesn't matter, because I think if it's a iris artisan or artiflex, probably that would matter. And which viscoelastic do you suggest to use on implantation? Well, I use Provisc and the usual methyl cellulose 2%. I used the mix, right? Soft shell inverted. I use a dispersive and a cohesive inside, so it helps a lot. Well, Dr. Jonathan is ready. Ready. Okay, can you start the case here?
Okay.
Okay.
Let's present the last case. No, it's the case 1. Sorry. Where's the presentation 2? Here. Is he, Herbert? Avisa ele que tá aqui. Okay. Can you see the presentation?
Yes, Rodrigo, perfect.
Okay, let's go. The last case, female patient, 41 years old. She wants the independence of glass and contact lens. She claims about blurred vision, and the ocular history has a high myopia, a light degeneration, and laser photocoagulation in both eyes due to a rupture on about 10 years ago, and not report previous eye surgeries. The familiar history is unremarkable, and the incorrect visual acuity is 2400. The refraction of these patients is on the right eye is -9 of spheric and -1.25. Sorry, 1.25 of cylinder. In the left eye, -7 spherical and -1 cylinder, and both correct visual acuity was 20/20. The main complaint is the intolerance of using contact lenses. On biomicroscopy, there was alterations, angle open, IOP of 10 and 12. We did the same propedeutic. The right eye, a little astigmatism and regular, 1.3. In the left eye, 1.4 of astigmatism and the same regular. A good cell density of endothelial cells. And this is retinal mapping due to the history of photocoagulation. And the right eye is down laser marks blocking and down temporal rupture. And left eye, 306-degree laser marks blocking lights. The biometry of IOL master, an LCD of 3.8 on right eye and 3.8 in the left eye. This is the calculation of the EyeCryl Phakic on the right eye. And this is the data that we use it to calculate, and the IOL is -12. We already did the surgery on right eye, and about 1 month of postoperative, she's 20/20 uncorrected acute vision, and a little astigmatism of 0.75 and IOP 13. The microscopy, we could see the whole of the lens, a good chamber. This is the pentacam of the postoperative. We could see the central hole of the lens. And now the calculation of the left eye, -10. Thank you. This surgery will be performed by Dr. Jonathan Lake, is the Chief Medical Officer of Opti Group. Thank you. Okay. Takashi, can you hear us?
Áudio compartilhar.
Okay.
Essa tá ali. Hello, guys, friends.
Yes.
I hope everybody's safe. Can you hear me?
Yes. And
okay, this is a very special day. I think this is a very interesting case because it is a high myope, but she's 41-year-old. And it's important for us to always measure accommodation independent of the age. And she can accommodate. She has actually J1. So it is a patient that has a certain risk for any kind of retinal problems. She'll always have to follow up with that, but she can accommodate, and she really wants to not use glasses anymore. So with these Phakic IOLs, now we have the opportunity to be able to assist these patients. So I think we saw all examples here before. I want to just show, we're going digital. When were we not digital, right? Andres and Lisandra and everybody, we're talking in Mexico and Uruguay and Brazil and Sao Paulo and Rio and everything. So, and we're all looking at a screen with a bunch of pixels here. So this is happening with surgery also. And we've had these incredible presentations during the week, and you should really watch it from Ophthalmic University. Ivo showing off the 3D platform. And I think it's not really the future, but it is really the present of ocular surgery. We had to do some anesthetic adjustments. So I'll just use a paracentesis here. It isn't fear. I don't like to manipulate it that much. And we have to really be careful because we're not performing cataract surgery. So usually I don't really mind if I open up the anterior capsule with a blade, but this is not something we want to do for this type of patient, obviously. So I just want to have a nice and comfortable incision. I don't want to force anything going in. So I'll just make it the correct size for us to go in. Let me see if I can go in comfortably. If not, I'll just use, there we go. So yeah, we're using the Ingenuity platform, which is from Alcom. I would like to thank them. And we're performing a lot of research here using this platform. Let me just, okay. This is very important. The marker has to be here at the left, away from us, and at the right.
proximal to us. So let me just finish opening the rest, and then we'll be able to discuss that further. Okay, opening beautifully. So this always has to be double checked at every single point, in which we have to our right here temporal, the marking, and this would be distal away from us, the left marking, which is right here. So I double checked that while I was holding, I double checked it while I was opening right now, and now we proceed to put in the last. And the last, I would like to say foot, but I don't think that's the correct. Last haptic here, let's be a bit better for this, and then we use this to centralize the lens. So here we have some beautiful vaulting. It's important, and we'll check this in the post-op. We use for calculation the white to white, the ACD. And we want vaulting at the end of the surgery, and we'll check that with any kind of OCT that we have here, or any kind of shine fluid, a vaulting between 250 and 700. And that with, I don't want to use hole, but with the orifice, or with the opening that we have right in the center of the lens, then we can kind of guarantee that vaulting. And this will preserve the crystalline lens for the patient. I'll need meiotic. With a meiotic, as we do in any kind of surgery with phakic lens or MIGS, we'll just push it out gently. We have this cohesive viscoelastic while we perform meiotic injection here. So we'll just pretty much left before, while we were entering the anterior chamber, and then we'll see the last remnants of viscoelastic coming out now. At the same time, we see the pupil closing nicely over the lens. Look, this is very standard surgery for anybody who is an anterior surgeon that's dealing with lens surgery. It is, we really feel familiar with it. If we take good care, double checking the markings of the lens, and also trying to handle the normal human crystalline lens carefully, it's a very safe surgery that we'll be able to perform in these different patients that we saw today. Okay, we have one little, there we go. That's the last remnant of our IOL, and just double checking here the intraocular pressure. And this is it. I think we're done for today, right? In terms of cases. Will there be another presentation? I was so happy that we were able to have BioFit supporting us for this. The EyeCryl has enormous patients, this type of market of high myopes and high myopes and high hyperopes. I have to remove the polarized glasses here. For high myopes, any kind of immature, it's not immature, it's any kind of high refraction. So it's a great option for treatment for these patients. And we do know that these patients are the patients in most need for this type of procedure. So basically, we're closing the gap between the patients that can operate and that cannot operate. We also have the high myopes, but I think keratoconus with extreme myopia is a very good indication. Dr. Rodrigo here is our reference for that. And it's great to be able to bridge the gap for all these patients. So once again, thanks to all of you residents, fellows, everybody from Ophthalmo University. Andres, great to see you again. Lisandro, Takashi, Daniel Moon. Special shout out here to André Rolim and André Lim, the two Andres, which are our official translators. They did a beautiful job because as all Latin American brothers here, so it's great to share languages and share our screens and share experiences together.
Thank you, Jonathan. What an amazing surgery, and what a great team you guys have over there in Brasilia. Congratulations to everyone. An amazing webinar. It's very complicated to do 3 live surgery. Hope you understand. And everything was fantastic. It was amazing. Rodrigo, I don't know if you have more questions or something else to share with the public.
No. I want to thank this webinar. And
I want to take advantage to time and invite all of you guys tomorrow with Jonathan, Noé Rivero, and Ivo Ferreira, Cracking the Nucleus, webisode number 3 in ophthalmouniversity.com. They will be talking about quick chop horizontal. So don't miss it. It's going to be great. It will be invited also Gustavo Hanin from Brazil, a great friend from us, Marcelo Reinhardt from Argentina, and Veronica Nieto Aguilar from Mexico. So a super team. Tomorrow, 2 p.m. Argentina and Brazil, that's the hour, and you are all invited. Takashi, how are you? Congratulations, my friend. Amazing webinar again, and thank you for let us be part of you guys and your team and Hope Brasilia and this amazing show that you just did. Daniel also, of course.
Okay, great. Thanks for having us.
Thank you.
Take
guys.
care, everybody.
Thank you.
Thank you so much. Good night.
Good night.
Good night.
Bye-bye.